Our next topic is endobronchial tuberculosis. The following chairpersons are requested to join us. Dr. Ajay Kotiala, Senior Consultant, Physician in Anand. Dr. Satish Patel, Professor and Head of Department of Respiratory Medicine at Pramukh Swami Medical College. Dr. Vijay Thakur, Senior Physician in Borsad. And Dr. Bhupendra Patel, Rathod, Consultant Pulmonologist and Intensivist at Anand. I would request Dr. Satish Patel to kindly introduce the speaker. Thank you.
Up till now, we have very important critical care presentations. Now we move for the pulmonary topic, very less entity like endobronchial tuberculosis. For this, I invite Dr. Alladi Mohan. He is a MD Medicine from the AIIMS, New Delhi. At present, Dean and Professor in the Department of Medicines, also Chief Division of Pulmonary and Critical Care Medicine, Sri Venkateshwarai Institute of Medical Sciences, Tirupur, Andhra Pradesh. He has many awards and the gold medals to his name. Very important brief important is the more than 330 publications in reputed index, international and national journals. Also edited 4 books, and more importantly, textbook of tuberculosis and non-tuberculous mycobacterium disease, 3rd editions. Also the member of International Advisory Board, Hutchison Critical Care Methods, 2nd editions, and also the associate editor, Lung India since 2010. Sir, please.
Respected Chairperson, sir, and the esteemed audience who have gathered here, I thank you for such a kind introduction. I come from the holy city of Tirupati. It's indeed a great pilgrimage for me to be here today at the holy place of Sardar Vallabhbhai Patel. I pray and place my homage for our great leader. The topic assigned to me today is endobronchial tuberculosis. I have no conflicts of interest to declare, and I have received no funding to deliver this talk. I was asked to have a little width in talking about a few things before and after endobronchial TB, so that the younger audience get benefited from that. A quick take on what is the TB situation today, that is in the post-COVID era. Actually, the year 20, year 21 data were not reliable because of COVID documentation, and the year 22 data was reported in the global TB report. We still have about 1/4 of the global TB burden and a little lesser multi-drug resistant TB compared with the rest of the world. But the point of interest is, we are the first country in the world to have our own model of TB estimates compared with what the WHO has been doing. This is a first, and this is the full publication, where it was shown that if you look at the WHO estimates, the Indian estimates are lesser both for incidence and mortality, and given that situation, we are making quick progress. We are trying to eliminate TB by 2025, much earlier than what other countries are aiming at. In this background, I will just place before you a very commonplace case scenario. I think most of the eminent physicians who are sitting here would have encountered. A 32-year-old man, typical history, right upper zone, mid zone patchy opacification, expert positive, R resistance not detected, treated for 6 months, big deal, what is there in this? But At the end of the treatment, no fever, weight gain, sputum negative, good chest X-ray resolution. Patient continues to have cough, progressive breathlessness. This is a very common problem faced by most of the physicians. Doctor is happy, smear was positive, smear became negative. There was fever, fever is gone. Weight was being lost, now he has gained weight. X-ray improved, but patient says, my cough is not gone. So there are some tangible things one should keep in mind while evaluating even a simplistic case scenario like this. I would begin in the conventional lecture mode regarding this topic because it is not well documented in most of the teaching learning aids. Endobronchial TB refers to the involvement of the trachea and bronchi by tuberculosis. Not a new disease. Quite some time ago, an English physician had documented this. So what is the burden of endobronchial TB? Endobronchial TB in autopsy studies, denominator being patients with TB, it is about 40%, wide range in these studies. Bronchoscopic studies, 10 to 20% of patients with active TB have endobronchial TB. How does the endobronchial infection occur? It can be by extension from the lungs by direct infiltration, implantation of the organisms from the infected sputum, hematogenous dissemination, lymphatic spread, or it can occur even as a part of the primary infection. The classical pathological descriptions of endobronchial TB date back to the pre-chemotherapeutic era. There are not many or virtually nil autopsy studies in the after 1950 on endobronchial TB. The earliest signs include erythematous mucous membranes, discrete tubercles with a rough granulated appearance to the naked eye, or shallow ulcers in the mucous membrane which progress to deep ulcers involving the bronchial wall. The formation of extensive granulation tissue may occasionally result in a tumor-like growth or a protrusion into the lumen of the bronchus, mimicking a neoplasm. The healing of the deep ulcers with consequent fibrosis and with contributions from edema and extrinsic compression by a lymph node results in bronchostenosis. Some of the rare presentations of endobronchial TB include post-obstructive pneumonia, presentation as a lung abscess, and obstructive emphysema and subsequent bronchiectasis distal to the stenosis. Microscopic appearances are typical. They are epithelioid granulomas. Please mind the spelling. It is not epithelioid, but it is epithelioid. Granulomas with or without a central zone of caseation, predominantly in the subepithelial region of the mucous glands. How do these patients present to us and when one suspects endobronchial TB? The clinical presentation is variable. It may develop during the primary TB, which is a common disease in children, or in post-primary TB, which we see in adults in high TB burden countries. The onset can be over a wide spectrum. Acute presentation, we have seen patients presenting with acute respiratory failure requiring mechanical ventilation. It can be a subacute presentation mimicking asthma, pneumonia or a foreign body aspiration, or the onset can be insidious with minimal fever, weight loss, rundown, cachexia, imitating a lung cancer. The classic symptoms are a barking cough, breathlessness, chest discomfort, fever, generalized weakness, weight loss, and hemoptysis, which can be massive also. The sputum production is variable, but bronchoria is not common. Physical examination, almost a forgotten art as on date. It may reveal diminished breath sounds or a localized fixed wheezing. The wheezing is classically low pitched, which is constantly present and heard over the same area of the chest wall, but it may disappear as the airways become progressively narrowed. A partial airway obstruction may on rare occasions act as a one-way valve leading to a tension pneumothorax. Unusual presentation includes expectoration of bronchial cartilages, fistula formation between the right and left main bronchi also. In addition to the usual chronic infections due to atelectasis and bronchiectasis, rare infectious complications such as pseudomembranous tracheobronchial aspergillosis on an endobronchial TB stenotic area has also been documented. It would be important to remember that bronchial stenosis is the most significant complication of endobronchial TB. It presents with slowly progressive breathlessness years sometimes after the diagnosis and treatment of pulmonary TB. If we revisit the case vignette with which we started, the sputum expert and smear become negative, fever goes off, weight gain is there. Patient continues to cough and has progressive breathlessness. One of the differential diagnoses to keep in mind is a possible endobronchial TB with bronchostenosis, which is occurring as a sequelae. Respiratory failure, difficult endotracheal intubation, need for tracheostomy, and death by suffocation may also occur as a consequence of tracheal stenosis. How do we ascertain the diagnosis of endobronchial TB? Most of the data are from the pre-expert era, where the conventional diagnostic methods give a yield of 15 to 20% smear AFB positivity, which is enhanced by another 10 to 15% when culture is coupled. But in the expert era, there is a focused paper on the use of expert MTB for the rapid diagnosis of endobronchial TB. The sensitivity is reasonable, but specificity is quite good. The specificity reflects expert MTB. False positives are virtually nil with expert MTB. So we can extrapolate confidently, even supported by this data, that testing the respiratory secretions with expert MTB would pick up the etiological diagnosis of tuberculosis. But one should remember that a negative smear for AFB or expert does not exclude the diagnosis of endobronchial TB. So these are all rule-in tests but not rule-out diagnostic tests. When the clinical hunch, clinical suspicion, clinical scenario seems appropriate, it is prudent to embark upon initiating anti-TB treatment rather than sticking to the hardcore science, because that can be life-saving. What does the chest radiograph show? Endobronchial TB, while it can occur alone, it often coexists with extensive pulmonary TB or even intrathoracic lymph node TB. Mind you, intrathoracic lymph node TB is predominantly a feature of primary TB, but of late, even in immunocompetent adults, we are encountering isolated intrathoracic lymph node TB, often presenting as pyrexia of unknown origin. Chest radiographs show patchy infiltrates, evidence of collapse or consolidation, but in 10 to 20%, the chest X-ray may be normal. Other radiographic features are hyperinflation, cavity formation, effusion, miliary infiltrates, and mediastinal adenopathy. Again, the computed tomography is a valuable tool. Findings are non-specific though. Endobronchial involvement of large, medium, and small airways are seen. Findings in small airways disease are poorly defined nodules, centrilobular nodules, bronchial wall thickening, and tree in bud. I will dwell upon the tree in bud a little bit for the benefit of the younger audience here. The typical tree in bud pattern, it refers to peripheral small centrilobular and well-defined nodules that are seen connected to linear branching opacities that have more than one contiguous branching site resembling a tree in bud. This picture is from my book. Samjot Dhillon and Nick Hanania had written this chapter. This picture is a classic, so one can understand these branching patterns you see here. With tree in bud on CT usually indicates infection vis-a-vis a non-infectious etiology. In histopathological studies, the tree in bud correlates well with the presence of plugging of the small airways with mucus, pus or fluid. Dilated bronchioles, bronchiolar wall thickening and peribronchiolar inflammation. The centrilobular lesions reflect solid caseation material within or around the terminal or the respiratory bronchioles. The terminal tufts of the tree in bud may represent the lesions within the bronchioles and alveolar ducts, while the stalk may represent a lesion that affects the last order bronchus within the secondary lobule. The other changes on CT include aneurysmal dilatation of the medium-sized bronchi due to endobronchial inflammatory tissue and evidence of stenosis or obstruction of the major airways. While CT is extremely accurate in detecting focal bronchial lesions, it is inaccurate in predicting whether the lesion is endobronchial, submucosal or outside the airway. Even with your 124, 256 slice multi-detector row CT, this is a caveat which you should keep in mind. However, the newer radiographic methods, multiplanar and 3D helical CT images with reconstruction and virtual bronchoscopy, they allow a better assessment of the tracheobronchial tree. EBUS is a very useful tool in obtaining the lymph node samples, while the curvilinear ultrasound is very useful for lymph node samples, while the radial probe ultrasound with the balloon is useful for visualizing the layers of the airway. The radial EBUS can show the destruction of the airway cartilage, which can aid in a decision to place a stent, as cases with damaged cartilage will not stay open after dilatation or local debulking. What are the other imaging methods? Outdated is bronchography. It is not performed these days. Bronchoscopy appears to be the gold standard as on date for endobronchial TB. This is the classification of the endobronchial TB by the bronchoscopic findings. This is the actively caseating type, the edematous hyperemic type, the fibrostenotic type, the tumorous type, the granular type, ulcerative type, and the non-specific bronchitic type. This paper by Chung and Lee is considered the landmark with regards to the bronchoscopic classification of endobronchial TB. The important point is to differentiate this condition from other mimics. Bronchial asthma, foreign body in children, endobronchial mass, malignancy, or TB coexisting with malignancy, NTM infection. A word about NTM infection, which is the newly emerging and understood disease. If you have a situation where the AFB smear is positive and the gene expert is negative, that is the starting point to consider NTM. Often, if we do only the AFB smear or if we do only the gene expert, we are likely to miss the NTM. Airway stenosis, focal stenosis, previous endotracheal intubation, Crohn's or Behçet's syndrome are the differential. Diffuse stenosis of the central airways, Wagner's granulomatosis, that is the old name. Granulomatosis polyangiitis is the new name for this. Relapsing polychondritis, tracheobronchopathia, osteochondroplastica, amyloid, papillomatosis and rhinoscleroma. All these are the mimics of endobronchial TB. There is a condition which is very relevant to India, anthracofibrosis. Anthracofibrosis is described in non-smoking elderly women who cook on the chula or the biomass fuel in a rural setting. This causes airway stenosis along with anthracotic pigmentation in the airway and peribronchial lymphadenopathy. Bronchostenosis due to anthracofibrosis usually involves multiple lobar or segmental bronchi, and unlike endobronchial TB, this spares the central airways. This condition is missed. Non-tobacco smoking women with weird respiratory symptoms are a special diagnostic problem in India, especially if the patient is from rural India. Not much has been published in literature regarding this. It's a good area to work on further research. Another a word about lower lung field TB. Endobronchial involvement is pretty common in lower lung field TB, and therefore there should be a low threshold to perform a bronchoscopic examination in such patients. In elderly, 15% of elderly with pulmonary TB have an associated endobronchial TB, and hormonal and vascular changes in pregnancy result in a airway edema and increased secretions. This can unmask or worsen the symptoms of an airway stenosis. In a HIV setting, the differential diagnosis of endobronchial lesions is more bizarre. Kaposi's, bacillary angiomatosis, lung cancer, lymphoma, again opportunistic infections. And as a component of immune reconstitution inflammatory syndrome, endobronchial extension of inflamed material from the mediastinal inflamed lymph nodes due to iris can also mimic the endobronchial TB. What about the treatment caveats? The classical anti-TB treatment is supposed to be effective, especially if started early. There is a school of thought that the corticosteroid treatment may perhaps reduce the chances of occurring bronchostenosis. This is highly debatable. There are no hard data, and we are not using a routine corticosteroid treatment in patients with active TB other than in some special situations. So how do we treat these conditions? This condition, bronchoscopic modalities include mechanical dilatation and debulking procedures. The barrel of a rigid bronchoscope or sequentially with the use of dilators, bouginage, or even balloons. It is called balloon bronchoplasty. Debulking of tissue obstructing the airway can be achieved by using a rigid bronchoscope to core the tissue. Curettage, etc., used for removal of the pseudomembrane has been described. There are thermal debulking methods using electrocautery and argon plasma coagulation. Thermal debulking using the ND-AG laser or this carbon dioxide laser, and bronchoscopic cryotherapy involving a contact cryoprobe that utilizes repeated freeze-thaw cycles for tissue destruction. Stenting using silicon, metal, or even hybrid stents is also being practiced. There are no prospective randomized trials to choose which is the better option. The experience of the clinician and the individual decision for the patient is helpful. Surgical treatment has been used and is still being used. Pneumonectomy and lobectomy are commonly performed for endobronchial TB in the past, but they have become unpopular due to a high operative mortality. New surgical techniques have been evolved. They include, the mortality is very low in these when resection along with surgical bronchoplasty, sleeve resection with end-to-end anastomosis is done. It should ideally be performed when the patient is no longer considered to have an active disease. To quickly summarize the key issues with endobronchial TB often presents atypically, and this results in a delayed diagnosis, missed diagnosis, even a messed diagnosis. So, a high threshold, a high index of suspicion and a low threshold to perform bronchoscopy would be the key to detect this condition early. Early diagnosis is imperative because of consequences like bronchial stenosis, which can be a significant contributor to the morbidity and mortality as well. Bronchoscopic methods are emerging, but there needs to be standardization and development of clear-cut guidelines for their use in the individual patient. The options are many, but the direction is not that clear. So, I will conclude with a brief epilogue after the presentation. Over the last 2 decades, idea was translated to become an iconic textbook. we are shortly on the way with the fourth edition of this textbook. Many of the people here would have been familiar with, and it is indeed a great opportunity to document how we see TB. The white man teaches us TB sitting in an air-conditioned room with over a cup of tea and biscuits, never seeing a patient. What a white man may see in a lifetime, our eminent colleagues here may see in a week's time. It is we who should teach the world how to manage TB. We have now our own Mera Bharat Mahan. India is the first country to have its own epidemiological model of TB. We are the first to come out with the Indian extrapulmonary TB guidelines, and I'm sure the work done in India will be the lead for years to come in TB management. This is what Mario Raviglione, who was the then director of Stop TB, told about the book, that a book that is conceived and produced in India is one of the major advances in TB care. So I would conclude by quoting from the Kenopanishad: "He by whom it is not thought out has the thought of it. He by whom it is thought out knows it not. It is unknown to the discernment of those who discern of it. By those who seek not to discern of it, it is discerned." With a humble submission, plea, request that the younger persons in this audience should take up TB research, should document meticulously the various facets of TB which only we are privileged or cursed to see in India, and we should lit up the lamp of understanding of TB for the whole world to benefit. I have come from a far off, obscure, unknown place. I am a small town physician practicing medicine as a professor. We have no commercial practice. We do teaching and research. But for me, this is a big moment to come to the land of Sardar Vallabhbhai Patel, whom I personally admire and respect. Chairperson, sir, and respected audience, thank you very much for the opportunity. If there are any queries, questions, bouquets, brickbat, stones, and even groans, I welcome them.
Thank you, sir. Any questions from the audience?
Can a bronchoscopy be completely normal with endobronchial tuberculosis?
Sir, it is a good question, sir. These days, by using a 3D helical CT and proper planning, it is fairly possible even to scope the more difficult cases hitherto where the procedure was not possible. When I started off, it was only a rigid bronchoscope. I have seen the transformation through a fiber optic bronchoscope, through video bronchoscope, through the newer bronchoscopes with lot of intervention ports. It is doable, sir, but not in all patients. Sir, usually the early initiation of the current modern short course anti-TB treatment should minimize the sequelae to less than 3 to 5%, 5 to 3% or whatever it is. However, in spite of the good immune status of the patient and early initiation within 2 to 3 weeks of anti-TB treatment, still some people go on to develop these kind of sequelae. Why is a question which has been bothering the researchers, because it is a TH1 versus TH2 cascade. Once it gets triggered and the TH2 takes upper hand, the progression is relentless in spite of the mechanical stoppage of the inflammatory process which is going on. So it is can we predict in whom it develops? Yet we don't have answers, sir. But we should be alert for the persistence of certain symptoms. If a person otherwise becomes what we call, quote, cured, unquote, but still he is not happy with his symptoms, it is prudent to think of this sequelae of endobronchial TB.
Sir, do you think TB can be eliminated from India by 2025?
Yeah, lovely question. You want the politically correct answer or? Yeah. Sir, the point is, I would guess that the whole TB elimination in 2025 has been badly railroaded by the COVID. COVID did good, tremendous use of face mask as a barrier, and people stopped spitting on the roads, and it did help TB in one way. But the TB instruments were used for COVID diagnosis. So whole 2 to 3 years, what happened? Did we miss the patients, or is it that TB has gone down? We don't know, sir. The politically correct answer would be, in light of the COVID debacle, perhaps it may not be easy, but realistically speaking, it is a little ambitious, sir. For that to occur, we need to look into not missing the cases with TB and also not missing the other things like NTM, etc. 25 is just 1 year away, sir. It's easier said than done.
One last question.
Yes, sir.
Is there any data of MDR TB in endobronchial tuberculosis?
Sir, MDR TB per se in dedicated endobronchial TB is, there are no reliable data, sir. What I talked with my friends in the TRC Chennai, etc., broadly in treatment naive patients, whether it is endobronchial TB or whether it is pulmonary TB or lower lung field TB, in treatment naive patients, MDR TB is less than 1%, sir. The problem comes with patients who have been irregularly, incompletely or inadequately treated. The other menace, someone was talking about use of levofloxacin. Levofloxacin is liberally used across the country, and what it is doing to the DRTB, programmatic management of drug resistant TB, is also an issue to contend with. My intelligent guess would be there is no higher predilection of MDR TB in endobronchial TB, sir. It is similar to what we see in pulmonary, lower lung field or otherwise.
Okay, thank you.
Once again, sir, thanks for the opportunity.
Thank you, sir. Thank you for accepting our invitation, sir. So, sir is father of tuberculosis of the country, and we all respiratory physicians have read his book, and we have become respiratory physicians by reading his book, TB by Mohan Sharma. So he is Dr. Alladi Mohan, sir. Thank you, sir, for coming here.